session basically is call it Meet the Experts. The main thing is, essentially everybody here is an expert in histiocytosis in the audience. So it's not to say that the others are not experts, but the whole point is to get some discussion started about what are the challenges, what are the opportunities, what questions are still in the open, including the questions that were raised in the session so far. So we'll invite a few of our colleagues to take the stage here and discuss those questions. And if you guys don't ask questions, they'll have to come up with some on their own. So we'll invite them and we'll ask them to introduce themselves one by one after they're seated. So Dr. Eli Diamond, Dr. Julian Haroche, Dr. Karen Reck, Dr. Eric Jacobsen. I think Dr. Go is, I think he got pulled away with the paparazzi, so busy. But yeah, so our esteemed panel here, so please introduce yourself one by one, your area, where you are, and then we can jump right into it. We'll have close to 30 to 40 minutes to talk about any burning questions.
Thanks, Gaurav. Eric Jacobsen from Dana-Farber. I'm in the lymphoma group and see the histiocyte disorders patients.
I'm Eli Diamond from Memorial Sloan Kettering, and I'm in neuro-oncology, but I see almost all of the adults with histiocytic neoplasms.
Hello, yeah. I'm Julian Haroche from Pitié-Salpêtrière, and I'm an internal medicine specialist, and I see adult patients.
Karen Reck, I'm here at Mayo Clinic in hematopathology, and so I diagnose lymphoma and also histiocytosis patients.
Thank you. Okay, so the floor is open for questions, discussions. Think about any challenging case you might have or a situation you want to be, to discuss within our community.
Hi, my question is regarding the how we use vemurafenib or MEK inhibitors, but mainly vemurafenib. If in this room, all of us use them the same initial dose. If we titrate it down or up, so what is the strategy that we usually follow? And for instance, in our center, we now do routinely in patients who are stable or in patients who reached some kind of partial response or complete response, we do this drug interruption, drug holidays. So I just wanted to have your, practice thoughts.
I'll take first crack. So for both vemurafenib and cobimetinib, I tend to start at a lower dose. I think probably the higher doses aren't necessary for most patients with histiocytosis. And in general, I've found that toxicity is not trivial at the 60 milligram dose of Cobi or the 80 dose of vemurafenib, or 960, I'm sorry. So I usually start around 40 of cobimetinib and even at half dose of vemurafenib. Thankfully, like here in New England, we get 2 months of sunshine per year, but those 2 months can be very problematic for the vemurafenib patients. So patients who have been on it long term and are stable, I'll often try to give them a holiday, maybe not for the entire summer, but for parts of the summer, recognizing that they're probably non-compliant for significant portions of the summer anyway due to phototoxicity. To me, the big questions are, what are the optimal doses of these drugs for these patients? As of now, I certainly counsel patients that indefinite therapy is necessary based upon Julian's data with the LOVE study and discontinuation resulting in pretty rapid recurrence in patients. But I wonder if down the road by combining multiple inhibitors and maybe using MRD driven approaches like we would use in other malignancies like ALL or CLL, could we viably give these patients more prolonged drug holidays with reinstitution of treatment if they, lose their MRD response or have some clinical sign of progression? But I agree. I do like to give patients who've been stable some type of treatment holiday periodically. What's that? I use cobimetinib now probably more than vemurafenib, and I've found with vemurafenib it's really the phototoxicity that was most troublesome for patients. For cobimetinib, I haven't had as many issues with having to give drug holidays as more just reducing the dose further. So from 40, I often go down to 20 in people who've been on it for a year or more, or maybe give them, instead of a week off, give them a couple of weeks off in between cycles. Honestly, it's probably more art than a systematic approach, probably more tailored by each individual patient and the toxicities that they've been having. So far there hasn't been a lot of inducible resistance. It is obviously a concern, but I think you have to balance that with if patients don't have these drug holidays or they are experiencing significant toxicity, they probably self-manage by not taking the drug. But try to at least do it in a somewhat controlled fashion.
I basically give people as little as I possibly can, unless they have parenchymal brain disease. So if someone does not have, like ataxia, like real parenchymal brain involvement, then I usually give dabrafenib as the first BRAF inhibitor, and I'll give 50 twice a day. And, if they're doing okay, then I may even just stay there indefinitely and COBI 20. If someone has parenchymal brain disease, then I will get them to like dabrafenib 100 twice a day, or COBI 40. COBI 60 is essentially invariably intolerable. And then if I give them for brain disease, I'll try for 480 twice a day as the target. And for people with the only exception would be someone who maybe has like tamponade, a pressing need to give a high dose at the beginning. But most of my dabrafenib monotherapy patients are on 50 twice a day, unless they have, ataxia, et cetera. I don't plan breaks, but if someone has a trip or something like that, or someone's like a sun worshiper, then a month or two is totally fine.
I do not really do breaks. I usually try to use VEM rather than dabrafenib, but it's probably because I never think to dabrafenib or to encorafenib, but you have several patients who have been frontline on dabrafenib because it's usually better tolerated, and I never do any more 940 VEM or 60 milligram COBI anymore. So I usually taper, and I rarely stop unless there is intolerable toxicity or having to explore, lymph node or something that's progressing, and then you're thinking to another pathology, overt malignancy or whatever. But I do not stop for vacation, probably because I would like to monitor the BRAF load or MAP2K1 load in the blood, and try to do something more scientific than just putting off, 3 to 6 months or longer. But it's interesting to try to stop and do some treatment holiday if you can organize that in a more having something more scientific, and I think that's what you're trying to do. But usually I taper and I wait until the next evaluation and the next question of the patient, saying my TEP is my PET scan is about the same. I have no symptoms.
what are we going to do next? I say, well, if you tolerate well, we can, remember how you were in the beginning. If you had, for instance, CNS involvement, and if the patient has recovered from everything, then he usually keeps on with the same regimen for an extra 6 to 9 or 1 year, 9 months or 1 year. And then we have again this discussion about stopping. And so, but usually I do not stop. Even if it's questionable, I try to switch drug and sync to better tolerated BRAF inhibitor. And I do not have the feeling that Mekinist is better tolerated than cobimetinib, and that Mektovi is even, I mean, the newer MEK inhibitor, I think it has the same side effects and profile than the MEK inhibitor. So it's just a question of dosage, in my opinion. But
So it's 3 weeks off every 3 months. So they kind of save about 25% of the overall dose. And we have 12 patients now on this protocol. And there is also a follow-up of 1.5, 2 years on average, but none of them had any sign of relapse. And so this is kind of encouraging me to continue to do so. And having established a sort of protocol of holidays, I think it's
so
it's
you stop 3 weeks every 3 months?
Yeah.
Okay. It's for both BRAF and MEK inhibitors, just BRAF?
we use mainly
Okay.
vemurafenib. Yeah.
Okay.
I have lots of patients who are week on, week off, or 2 weeks on, 2 weeks off.
That's
Probably-
a lot.
What's that?
Yeah, that's a lot. That's a lot of.
It's a lot of time off.
Yeah.
Yeah,
Yes.
but I've maybe a couple people relapsed, but they were, someone who had like 1 week on, 3 weeks off, but very, very infrequent. More commonly, it's fine, I found, and it makes it more tolerable.
Yeah, I agree.
Yeah, because sometimes the problem is that they cannot even explain why, but they feel bad. It's like they feel weak. They have some arthralgia or something that they cannot really explain. But when they're off, it's okay. Some patients say, I'm doing better, and I don't know why.
Is that on? Yeah. So, Eli, I think you used the caveat there when you were saying on the dosing and stuff, except for parenchymal diseases, CNS parenchymal diseases, on the dosing. And I just wonder, because I have another patients, even though they have a known mutation, so they have BRAF and then on venrafenib, that they don't get good control or the disease starts progressing on it. And I guess my question is what are people using now as maybe a additional therapy with them if they can't, travel to New York and get the trials that you're doing there? Is there benefit in adding anakinra or such to the venrafenib or the cobimetinib in that setting?
I have only experience with only one patient who was an anakinra plus MEK inhibitor, and I don't feel there is any interest for that. But I would rather. I mean, there are a couple of patients who are on BRAF inhibitor with arthralgias who need sometimes low dose steroids, but I've never used anakinra plus BRAF inhibitor.
I have a partial answer to that question and a question myself. So I would give that guy low dose clofiramine in addition to the inhibitor. Well, I found that to be successful in a couple patients. My question is about hypocalcemia in patients on cobimetinib. I have a 21-year-old with multifocal relapsed LCH who has developed a calcium level of 6.8 and has required mega doses of oral calcium and vitamin D to get his level back out of the danger zone. And I've obviously stopped the cobimetinib, but I'm just wondering what your experience has been with patients who develop hypocalcemia. Can you put them on a lower dose of cobimetinib, or you just have to keep them supplemented all the time?
I've never seen this side effect personally.
Neither have I.
Yeah, I haven't encountered it. I mean, everyone in Boston is vitamin D deficient, but
Well, I mean, it's listed.
but you're in
the side-
Texas.
Yeah, I know.
Funny
It's
stuff.
listed in the side effects.
No, it is, but I've
Yeah.
not, I've not encountered that degree of hypocalcemia, I have to say.
Yeah, I haven't seen such a case, although we don't routinely measure calcium level. Was that just incidentally found, or was the patient symptomatic, or do you do calcium checks every month?
Well, it's part of our protocols to do the Chem 10 every month when they come in.
Yeah.
And he did develop numbness. He didn't have Schwastek sign or any other more serious things, and he could ambulate fine, but he was a little symptomatic.
And what dose was that on of COVID?
That was on 60
Oh, I would imagine that would be better with a dose reduction.
with 40 or 20.
Yeah.
Yeah.
I would guess.
I actually don't know the mechanism of the hypocalcemia. I just have to, I don't know if it's a direct effect of MEK inhibition or an off-target effect. I'm just not, I don't know. I'd have to look into that.
I don't know the mechanism. No, that's a good idea. Yeah. Mhm. Thank you.
Any of you after disease regression with whether it's BRAF inhibitor or MEK inhibitor have tried to target the clone with a specific therapy so it doesn't relapse? Like, have you used after disease stabilization or regression something else to target the clone itself?
So I think I have a couple patients, like 2 or 3, who went back to PEG interferon, and it's interesting because if you look at the BRAF load in the peripheral blood, in a couple patients who were under BRAF inhibitor, you can find the BRAF in the blood. Whereas if they are treated by either chemo, which I don't do, or PEG interferon, it's not detectable. So it's something which is not, it doesn't seem very logical, but it could be an argument for treating with targeted therapy and then after do not stem cell transplant, but probably do chemo or I think there was a trial like that for it was in kids, if I remember correctly. It was rather LCH.
I've given 2 adults cladribine once they achieved a complete response, and they was only 2. They relapsed on the cladribine, and then I've given a couple sort of like oral methotrexate more as like a suppression, and they relapsed as well. And I think I tried cytarabine once. So I have been not systematic, but it hasn't, I'm open to ideas, and maybe I just had bad luck, but those few cases didn't work.
Yeah, I haven't tried it. If someone's responding, I generally haven't added other agents, so I don't have any experience with that.
Yeah. So at least in my practice, we usually we talk about treatment options, of course, the targeted agents, and also the option of using chemotherapy. And most patients would choose the targeted agent, but some would rather have the chemotherapy shorter duration. So we haven't done much of TKI remission consolidation with chemo. Usually it's the other way around. Patients don't like TKIs because they heard about it or talked to other patients and go straight to chemo. And, probably about a third of them, half of them will probably go in remission with cladribine, and maybe a third or a fourth, about a third of them actually, those who go in remission, 30 to 40% will stay in remission. Now, we don't serially check for BRAF tumor load in the blood. We only look clinically. Yeah, so there are patients who go on very long-term remission, 5-10 years.
So if the patient goes into remission on cladribine, do you stop it or?
Oh yeah, well, it's we usually don't give more than 2 to 4 rounds of chemo. Done, yeah.
I have a question. And also, I noticed Karen is in the expert panel, so it involves a multidisciplinary discussion, I guess. But the thing that was brought up earlier from Dr. Pikarsik's presentation is, what do we call ECD today? We see these various flavors of cases since the awareness is so much that Dr. Bach's presentation showed that cases may not have bone involvement early. And History of Society, I think in 2016, talked about classic, non-classic ECD. And I think we tried to do that study recently as well, found that there is a cohort of adults we are calling ECD and treating like ECD. We are not as the description of original ECD in 1930. And there is a biography of Dr. Chester, I think, in our packages, and written by Dr. Walter Rush, who's a dermatopathologist, I think, in Maryland, who raised the question that, are we, what we are calling ECD was the original intended ECD. And it does have implications for management because I don't think a pathologist is calling it ECD on the biopsy report. So is there something that we need to be discussing among ourselves or as in scientific community? What is ECD today?
If you have a single organ involved, would you make a diagnosis? If I can piggyback on your question, if you have a single organ that's involved, would you call that patient ECD? And maybe we can just start by going yes or no, and then have a discussion around it, because I think that will help frame our discussion.
Yeah, it depends what kind of involvement it is. But if you have for instance, tamponade with a typical aspect of heart involvement by something you think is ECD, you have no long bone involvement, but by whatever means you're exploring the bones, and you have high CRP and a biopsy of the pericardium that shows you tout en cell. And eventually, if you find a BRAF mutation, or then I think it's called ECD, even if you don't have long bone involvement. So it depends. What if you find just I don't know, an adrenal mesenteric paniculitis with an histology which is where you don't have phospho-ERK staining and you don't have BRAF mutation, no long bone involvement, and the two pathologists don't really know, don't really agree together, then I don't think this would be called like ECD, or you would have to repeat the biopsy. And so it depends the site of involvement, if you have a mutation, and the clinical radiological pattern. I mean, the radiologic pattern is important along with the rest. And sometimes, just to what you were saying, is that sometimes the pathologist, they say sometimes it's ECD. In the conclusion of the report, they say this is not typical but compatible with ECD if if the clinical presentation is compatible, and then the pathologic report, the pathologist can say, is there this and this? So he asks you a question, but he can say it's non-specific but compatible with.
Yeah, I think in my pathology reports, if the histology is compatible, but I don't have any genetic confirmation, then I would say, like Dr. Frosch said, the words that I would use would be compatible with ECD in the appropriate clinical and radiologic context. But if I had a biopsy that had a confirmed BRAF mutation or MAP2K1 mutation and everything else was consistent, then I would say consistent with Erdheim-Chester disease.
How many of you would call a 4-year-old with it in the brain in the case that I presented, ECD? So does age matter is the next question.
Fortunately, I don't see 4-year-olds, but
Good answer.
I mean, I think age matters in the sense that, like in the case you presented for a kid with JXG, once there's the BRAF mutation, it is enough like ECD. I would defer to Ken, but that you'd give it targeted therapy. Whereas if it was mutationally otherwise, you'd probably try chemotherapy. I assume there's more at stake in the name, I think, in kids than in adults.
I wouldn't think
Ideology.
age alone would be a disqualifier. Occasionally you see pediatric melanomas, or you see very rarely adolescent CLL, so diseases that you don't think of as pediatric malignancies, that are certainly better characterized than ECD do in very rare circumstances occur in kids. So if it was the correct histopathologic appearance and a typical mutation, then I would agree with Ron. I don't see 4-year-olds, so I won't have to make the decision, but I personally would say it would be consistent with ECD.
yeah, I think it's a similar question to pathologists. If you send a biopsy, skin, it's xanthogranuloma, but you don't give the age, would you say you probably would just say XG without the A or the J? Although under the microscope, the A and the J, they look exactly the same. Yeah.
Yeah, that's right. And if you had a BRAF mutation, then you would say definitely stage the patient. So, to think about the analogy to lymphoma, we don't change our diagnosis of lymphoma based on the site, if it's unifocal or multifocal, but of course then they have to stage the patient to determine the appropriate treatment. So it's probably more similar to lymphoma in that way, in that both the histology and the phenotype and the genetics, as well as staging studies, determine the treatment.
Maybe one question to the panel here. As far as isolated ECD, which sites have you seen isolated? For example, CNS isolated ECD, bone isolated ECD. How about the other organs, say hairy kidney alone with nothing else? Have you seen that, or cardiac alone and nothing else?
Definitely seen bone alone. I've had a number of patients who tear an MCL playing pickleball or tennis or something, and they get an MRI eventually, and they do have a torn MCL. It was an acute injury, but oh, by the way, you have these sclerotic lesions in your tibia and your femurs. And so that was actually one thing I was going to throw out there in those patients who are diagnosed really incidentally with a non-critical organ affected. I mean, I like my legs, but the sclerotic lesions of the distal long bones are not life-threatening. Do those patients require therapy? Personally, I observed those patients. I think in that setting, it's very much like a low-grade lymphoma where immediate therapy probably is not beneficial, but I admit to them that I don't know that that's the right thing to do. And I actually have a case now of a patient who has isolated hairy kidney that we think is ECDs, had 3 needle biopsies that have shown foamy histiocytes, but they haven't been able to demonstrate a mutation. The NGS hasn't worked, and the urologist is very nervous about doing a more invasive biopsy because of the risk of bleeding and potential need for nephrectomy. So we're struggling with that. And again, this was incidentally discovered. after a motor vehicle accident. So for now, I think we'll probably observe him, but it does, for all the world seem like ECD.
When you mean single organ, like you don't have the iconic long bone, like no uptake whatsoever. Okay, so like you're speaking of the rare of the rare. Yeah, I have a couple patients, maybe 1 or 2 patients with a so I think it's very, it's very rare. Yes, yeah, heart involvement, but in that case, I do not remember if I have had a complete long bone involvement with PET, MRI, a bone CT scan, and plain radiography. And if everything is normal, in the case I'm thinking about, this would be the unique heart involvement. And I have also 1 or 2 solid histology of mesenteric panniculitis without long bone involvement and with a MAP kinase activation in the. But I think with no long bone involvement, it's very rare, I guess.
I think I have 1 or 2, 1 cardiac only. Yeah.
I've never seen isolated involvement of anything but bone or retroperitoneum. I've never seen isolated CNS or cardiac or aortic involvement or other organs.
I think the isolated bone is an interesting phenomena. I acquired a patient that was originally on one of Juvy's original patients in study with in our case, it wasn't pickleball, it was a ski incidental finding, but yeah, he's part of the group. He's been labeled as ECD for years now. And I'm troubled on what, am I continuing to do these evaluations because nothing has changed yet. We had a NIH-worthy review of being diagnosed as ECD, but he had a single bone lesion. So I think back to the original question, I think there may be an opportunity for a subtype of lesions, and then maybe when we come up with recommendations on follow-up, we may have to think about what extensive involvement do we do after workup after we follow up do we do with these patients who have a single bone lesion, just like in it's more common in LCH to see a lesion, and sometimes they even go away on their own.
In the ECD, or I think most of us have seen patients with single organ involvement that falls, let's say, within the ECD orbit. Whether or not you formally want to label that patient as ECD, I think is up to you. For example, I presented a really CNS only with bearing the BRAF mutation, who responded very well to them and Kobe, and I think others have seen that. Separate question, and even Ken and Carl can jump in on this. Do you think that a lot of us will leave patients who really don't have very clinically significant disease, maybe mild degree of disease, watch them untreated? Do you think long-term that may predispose those patients for either a neurodegenerative disease or perhaps irreversible cardiac involvement, maybe 10, 20 years down the line? We don't have, I know there's no data on this front, but does anybody have any speculations?
I think that in general, the constellation of organ involvement at diagnosis doesn't change, so someone doesn't develop neurologic disease 10, 20, 30 years later. Since I've, inherited Dr. Heaney's practice, because I had not appreciated how many mild ECD patients there are out there off treatment, because he followed, probably a good 20, 30, LCH or ECD patients off treatment that I just never saw. So there are people who are just fine for a very long time and just need to be left alone. And I don't think they've acquired, problems over the time.
So the only thing to keep in mind is probably if it's a BRAF mutated patients, like you could imagine by analogy with LCH, that maybe 15, 20 years later, they could develop neurodegenerative,
Right.
if they are not
Yeah,
treated.
these people by definition, I don't know their
Yeah.
mutation because their biopsy was, to probably maybe they're wild type.
But
It's been a long
I
time.
guess the counterpoint is, if they did have BRAF mutated disease and you started them on vemurafenib, they could be on vemurafenib 15 or 20 years from now, and we don't know the long-term consequences of being on a BRAF inhibitor that long. So I kind of go back to what I know best, which is lymphomas, and there's no study in any low-grade lymphoproliferative disorder showing that immediate intervention in an asymptomatic patient without complications is a benefit. So obviously it's not a perfect analogy, but it's probably the closest analogy we have.
And sorry, the only thing I'll say is I'm often skeptical that people are really asymptomatic because I think that they've had this for so long that it's become invisible. They're like, you're not supposed to have night sweats, and they think of themselves as well. But if you kick the tires a bit, they may not feel that well. So
Right. So
without organ dysfunction, but it may not be mild to them. Yeah.
Yeah,
The burden of proof is against it unless someone really, really feels fine. But usually if you ask, they don't feel great.
Yep. No, yeah, but I think there are a lot of patients, or a lot, I don't know, but it's frequent to have patients with either no bone pain or just very mild bone pain because you ask them, because you have, they have bone pain, but you would ask them, and do you think if there's a French movie like that, if you eat tête de veau vinaigrette, I don't know how you say that, do you think it would itch you? And say, oh yeah, maybe it would itch me. So if you dig, you find, and so anyway, sometimes they have just a little tiny bone pain or no bone pain, but with a typical iconic images, and they have high CRP, like 20 or 30. And these patients, I think they should be treated or prevented for development of amyloidosis after 10, 15 years, because if you keep on with the CRP, with even with just, I have seen at least two patients with histiocytosis, two Erdheim and one Rosai-Dorfman, who developed this but it was like really multi-system, but someone who has a chronic disease should at least be under colchicine to prevent this complication.
I think you just have to balance that with, the reality is most people don't feel that great on vemurafenib or cobimetinib either. So are you trading mild disease-related symptoms for toxicity?
No. For this, if in that case, I would definitely not give targeted therapy. I would give either very low dose PEG interferon or anakinra if he accepts to have an injection every day, or have 2 or 3 patients who have a definite proof of ECD, CRP, and either no bone pain or very moderate bone pain that they just take painkiller, paracetamol from time to time.
Ron, what do you think? I don't want to put you on the spot.
You just did, but
Yeah, I know.
Yeah.
It's like, I
Yeah.
won't take up a lot of your time. But
yeah, no, I
30
agree.
minutes.
I have patients who were incidentally found observed just like Dr. Haney's patients, and being a hematologist, and previously practiced lymphoma too, then we have that concept of, got to find the indication. We don't treat all cancers, curable you treat. If it's not curable, then you have to, the treatment has to benefit, whether it's improve survival, prevent complication, or improve quality of life. And if you don't meet any of those criteria, then the default is observation. I have seen, though, maybe certainly some patients without neurologic symptoms or findings, although I guess I have to say I'm not a neurologist, so probably I didn't do a very good neuro exam at the beginning. And then, after you treat them with BRAF agents, all the lesions are gone that are visible, whether it's in the brain or elsewhere. And then you see them having all these quote unquote, neurodegenerative findings, cognitive, balance without brain lesions. So I've seen some of those over time, and kind of makes me think about that question, the neurodegenerative, if you treat, do you prevent that? At least in some of those situations, it did not prevent, or it did not make it stop the progression if it was there already. Yeah, that's a huge challenge. And I maybe I'll throw this back to the experts here. If there are anything kind of coming, there is anything coming along that line, neurodegenerative management of histiocytosis?
Apart from tyrosine kinase inhibitors that penetrate better the
brain.
Brain.
Yeah, I think that there may be an incremental gain from CNS penetrant
Higher
targeted
doses.
therapies. Yeah.
Which is actually what I'm in planet. Certainly, if you want to put the best generation, early treatment and prevention of, let's say, visible brain disease. These are really inexact analogies, but something. And what were your patients treated with? Who's treated? You're talking fat inhibitors?
Yes, either Colby or vemurafenib. Some certainly had cladribine. Yeah, some different types of therapies. Yeah. Are we about?
Yeah, I think maybe one last question, and then we'll move on.
So following back on Dr. Goyal's question, and also some of the experts who have asked the same question, is it time for us to redefine what we call as ECD, based on, we can have ECDGA and Histiocyte Society consensus? Should we restrict the terminology of ECD only to this classical phenotypes and the isolated organ involvement, especially the isolated CNS histiocytic lesions with somatic mutations, not meeting the criteria for Rosay-Dorfman disease of Langerhans cell histiocytosis? Should we go away from the terminology of calling those as ECD, rather call them just as histiocytic neoplasm NOS? So is it time for redefining the terminology of ECD?
We have to have a consensus in 15 minutes. Okay, good. Yeah.
For what? No. For what should we? Why is it time to have this new? I mean, I wouldn't change personally. I think it's sometimes we're facing some difficult situations, but it's not really. I mean, there are some more urgent things to do, but that's personal.
I think it's time to maybe reflect on what's at stake in the question, and I'm not always sure that the label, of isolated ECD or, an intracranial non-LCH with a mutation X. I'm not sure there's much of an implication, in that instance, so.
Right. Well, I mean, the trend in heme malignancies has been to split, right? I mean, no one uses the FAB classification of leukemia anymore. We define it based upon molecular abnormalities. Lymphomas are defined now, there's 13 different kinds, I think, of large cell lymphoma now. They're defined largely by molecular abnormalities. Some we can act upon, many we can't. But because we can't act upon them now doesn't mean we can't in the future. And it doesn't mean that they're not biologically distinct diseases that, warrant maybe separate trials or separate investigations. So I think from a practical perspective, splitting probably doesn't make a difference for the clinician. But I think for somebody studying the basic science of the disease and somebody in developmental therapeutics, it does make a difference. Now, obviously, it's a challenge when you have an incredibly rare disease already. And if you're trying to parse it down into various cells of origin or various mutational profiles, it's going to be difficult to accrue patients. But I'm a splitter. So I think I agree with the comments that there's probably not a practical implication at the moment, but I think biologically that, these are likely to be distinct processes.
I mean, does WHO recognize adult xanthogranuloma as an entity, or is it all JXG?
There is a category of disseminated JXG in the WHO,
So, so
but it's not clear actually how you distinguish that
yeah,
from
because
ECD.
they've been called anything, So when we ask question about how many cases do you have with isolated, your denominator is also maybe affected by that, because some of these patients are not even coming to ECD clinics because they're not being called ECD. I'm just throwing it back out there. I've seen cases certainly with brain lesions, BRAF V600E. What do we call them? And then JXG is the name itself has juvenile in it. So, those it also affects access in that sense. Do they go to a histiocytosis and like what do they have? And I think that's what I was trying. I think some of us were trying to get at is,
Yeah,
like,
I
or at
think-
least go to classic, non-classic ECD. I'm again, it doesn't have to be redefined in 5 minutes, but the Endo Society changed the name of central diabetes insipidus last year. So, maybe we can achieve a consensus of some sort to
Yeah.
define in that sense so that those patients can at least be under an umbrella. Do they have XG? Do they have ECD? Okay, who do they see? What community do they,
Yeah. So, in the last year, in the hematopathology community, we've undergone reclassifications. And in addition to the 5th edition of the WHO classification, there was a separate group that published an international consensus classification, which is separate but completely overlapping. And there are many differences between the two. There's many similarities between the two classifications, but there are also many differences, some of which are important and some of which are just semantics. But it's created a huge problem because of ICD codes, because of insurance coverage, because of diagnostic confusion, and it's increased the workload of the hematopathologist because we have to reference the WHO revised 4 classification, the WHO 5, and the ICC, and indicate what the diagnosis would be in each of those 3 classifications. It's incredibly confusing and verbose. So it's been very difficult. So I think when we're considering renaming things, we should have a very clear reason, and it should be a clinically significant reason to change a name. So I think until we have those clearly defined entities that we know are biologically different, and that maybe have potentially different therapies, either now or in the future, that we should keep things together until we can have more information to separate them out.
Yeah, I think this is classic, but clinicians learning from our pathologists here.
Mhm.
Yeah, and I can't agree more.
all.
You can always use the data to subclassify within the diagnosis, where it does matter for prognosis and what you might do in your treatment and what you might do in your monitoring the patient. So, for the myeloproliferative neoplasms, the PVR and stuff, we don't call one JAK2 or not JAK2. We still call it polycythemia vera, but we know that their prognosis can be different, so we might monitor them differently. So I think that's probably the same ways where we should be going with ECD. So we just may need to think about it when we write up guidelines and stuff, that we indicate that, with these findings, and maybe if we get more of the cluster data that was presented, and if those truly pan out, that then we can have, say, well, if you have these findings, you need this kind of treatment and follow up. And if you don't, then maybe the follow-up might be different. There's opportunities.
Well, in the interest of time, I would say we will close this session and move on. To thank all our experts, our esteemed panel.